Have you ever wondered why the cows stopped smoking weed? Well, it came to the point when the stakes were too high. Hope you found that amusing. Hello, everybody. It's Ryan here. Hope you and your family are well. Thank you for joining me even as we unpack chronic obstructive pulmonary disease today. This is the outline of our talk. We're going to be addressing a clinical question just to give us some kind of context. Then we're going to break down COPD in terms of the key points, an introduction, and then we're going to look at etiologies and why people get COPD, what are the risk factors, look at patient presentation, signs and symptoms to elicit a plausible differential diagnosis. We look at diagnostic evaluation and investigative workup, treatment and management options as per the GOLD criteria, which is the Global Initiative on Lung Disease. Then look at prognostication and complications, and of course end off with the scripture. God bless you. Thank you so much for joining me, everybody. Alrighty, I hope you and your family are well. We're going to start off with a beautiful clinical case. A 70-year-old man with known COPD is seen for follow-up. Now, he has been relatively clinically stable without an exacerbation for the last 6 months. Well done. However, he generally feels in poor health and is limited in what he can do. He reports dyspnea with usual activities. He is currently being managed with salbutamol metered-dose inhaler twice daily as needed. He has a 50-pack year history of smoking and has quit 5 years prior. His other medical problems include peripheral vascular disease, hypertension, and benign prostatic hyperplasia. He is managed with aspirin, lisinopril, hydrochlorothiazide, and tamsulosin. On examination, the patient has a resting oxygen saturation of 93% in room air. He is hyperinflated to percussion with diminished breath sounds at the apices and faint expiratory wheezing. His pulmonary function test demonstrates a forced expiratory volume in 1 second of 55% predicted, quite significantly decreased, a forced vital capacity of 80% predicted, and an FEV1 to FVC ratio of 50%. What's the next step in his management? Well, is it A, initiate a trial of oral glucocorticoids for a period of 4 weeks and initiate inhaled fluticasone if there is significant improvement in lung function? Is it B, initiate treatment with inhaled fluticasone 110 microgram twice daily? Is it C, initiate treatment with inhaled fluticasone 250 microgram in combination with inhaled salmeterol 50 milligram twice daily puff? Is it D, initiate treatment with inhaled tiotropium 18 microgram per day? Or is it E, perform exercise and nocturnal oximetry and initiate oxygen therapy if these demonstrate significant hypoxemia? Guys, here are our key points to take home, right? Before we even get started, these are the headlines that we have to know about COPD. So chronic obstructive pulmonary disease, COPD, is airflow limitation caused by an inflammatory response to inhaled toxins, often cigarette smoke. Alpha-1 antitrypsin deficiency and various occupational exposures represent less common causes of COPD amongst non-smokers. Now, symptoms are productive cough and dyspnea that develop over years. Common signs to look out for are decreased breath sounds, prolonged expiratory phase of respiration, and wheeze. Severe cases may be complicated by weight loss, pneumothorax, frequent acute decompensation episodes, which are called exacerbations, right heart failure, and or acute or chronic respiratory failure. Diagnosis is simply based on history, physical exam, which are the basic tenets of medicine, chest X-ray, and pulmonary function test, your PFTs. Treatment is with bronchodilators, corticosteroids, and when necessary, oxygen, antibiotics. About 50% of patients with COPD will unfortunately die within 10 years of diagnosis, guys. All right, COPD is a progressive, irreversible, that's the word, irreversible airway obstruction, usually caused by tobacco smoking. It is the 4th leading cause of death in the States. Now, it presents as a spectrum, as either one of 2 pathological conditions. On the one end, we have chronic bronchitis. On the other end, we have emphysema. So chronic obstructive bronchitis is a disease of the conducting airways and terminal bronchioles. Clinically, the definition of chronic obstructive bronchitis is when the patient has a productive cough, which lasts for more than 3 months per year for 2 consecutive years. So it's defined as a productive cough lasting for more than 3 months per year for 2 consecutive years, plus you got evidence of airway obstruction on your pulmonary function. Emphysema is a bit different. Emphysema is defined pathologically as a permanent enlargement of air spaces distal to the terminal bronchioles, together with destruction of the parenchyma, causing closure of the smaller airways and loss of lung elasticity. Okay, let's look at etiology, epidemiology, and risk factors, guys. But pathologically, COPD can affect any part of the respiratory tract. In the conducting airways, chronic bronchitis predominates and results from the irritant effects of smoke-induced expansion of those mucus-secreting glands. In the terminal bronchioles, there is increased airway resistance caused by smoke-induced lymphocytic airway wall inflammation. In the lung parenchyma, there is smoke-induced emphysematous lung destruction caused by an imbalance of neutrophil, macrophage, and interstitial proteolytic enzymes that damage our beloved gas exchange units. Acute exacerbations of COPD may be idiopathic, infectious, or environmental in nature and generally present with significant respiratory distress. Lung dysfunction results from dynamic hyperinflation caused by airflow limitation, and that there is number 1, loss of elastic recoil, number 2, increased collapsibility, number 3, narrowing of the small airways. All right. And number 4, impaired gas exchange in the way of ventilation perfusion mismatch, alveolar destruction, increased dead space, which contributes to hypercarbia. Reduction of the total minute volume and increased work of respiration as a result of increased airway resistance, hyperinflation, and ventilation perfusion mismatch eventually results in alveolar hypoventilation, hypoxemia, and hypercapnia, right? Risk factors, as you know, include traditionally cigarette smoking, which accounts for upwards of 90% of cases, together with air pollution, occupational inhalation, and our beloved alpha-1 antitrypsin deficiency, which gives you low predominant emphysema in young non-smokers. Only about 15% of smokers develop COPD. A genetic predisposition to COPD is thus deemed as a likely factor. All right, here's a beautiful picture from Harrison. So what we can appreciate here is the pathogenesis of emphysema, right? Upon long-term exposure to cigarette smoke in those individuals who are genetically susceptible, lung epithelial cells and both B and T lymphocytes recruit inflammatory cells to the lung. Biological pathways of protease-antiprotease imbalance, oxidant-antioxidant imbalance, apoptosis, and lung repair lead to extracellular matrix destruction, cell death, chronic inflammation, and ineffective repair. Now, although most of these biological pathways influence multiple pathobiological results, only a single relationship between pathways and results is shown. So, triggers things like cigarette smoke and genetic susceptibility, right? These then engage your effector cells in the way of macrophages, neutrophils, epithelial cells, lymphocytes. Biological pathways has to do with the protease-antiprotease interaction. Remember that the proteases destroy the lung connective tissue. Antiproteases try to prevent this process from happening. What happens is the proteases usually predominate and we end up with emphysema, right? So the pathological result of that is extracellular matrix destruction. On oxidants and antioxidants as well, that balance, tips in the favor of your oxidants, and you get chronic inflammation. Apoptosis results in cell death. Lung repair, because of inhibition of certain mediators like transforming growth factor beta, elastin, lead to ineffective repair. Okay, that underpins the pathobiology of COPD. Now, patients usually have some combination of chronic bronchitis and emphysema. Symptoms of bronchitis proverbially are called the blue bloaters. We'll look at a beautiful diagram coming up. And the predominant presentation includes productive cough, dyspnea, fatigue, rhonchi, wheezes, cyanosis, hypoxia, and obesity. They are edematous and they are cyanotic. This versus symptoms of emphysema, proverbially termed the pink puffers, which is the other end of the spectrum of COPD, which includes severe dyspnea, minimal cough, increased work of breathing, decreased air movement, prolonged expiration, accessory muscle use, barrel-shaped chest, pursed lip breathing, weight loss, tripod posture, and hyperresonance, right? And the symptoms, of course, include severe dyspnea, minimal cough, increased work of breathing, decreased air movement, prolonged expiration, accessory muscle use, barrel-shaped chest, tripod sitting, hyperresonance. We mentioned this, right? The cause is frequently complicated by acute deteriorations in respiratory status, which is what we term exacerbation of COPD, usually due to some acute respiratory irritant, be it a viral or bacterial infection or environmental exposure. Defined clinically by increased cough, number 1, Number 2, change in sputum quality or quantity. And number 3, worsening dyspnea. So the 3 things which define an exacerbation of COPD include number 1, increased cough. Number 2, change in sputum quality or quantity. Number 3, worsening dyspnea. Okay, here's a beautiful diagram or cartoon from Mr. Jorge Muniz over at midcomic.com. Thank you so much, sir. Showing us the two parts of the spectrum, really, of COPD, the chronic bronchitis on one hand and the emphysema on the other hand. So this is your chronic bronchitis, which is the clinical diagnosis of daily productive cough for 3 months or more in at least 2 consecutive years, versus emphysema, where the pathological diagnosis is that of permanent enlargement and destruction of the air spaces distal to the terminal bronchiole. So chronic bronchitis is the clinical diagnosis, emphysema a pathological diagnosis. So you think about the blue bloater, he's edematous and he's cyanotic, right? He's overweight and cyanotic, has elevated hemoglobin, peripheral edema with wheezing. But the pink puffer of emphysema, he is older and thin, he has severe dyspnea with a quiet chest, right? Together with hyperinflation in the lungs and flattened hemidiaphragms. Guys, what's the differential diagnosis for COPD? Well, it could be congestive heart failure, could be asthma, which is reversible airway obstruction, could be bronchiectasis, pneumonia, pulmonary embolism, pulmonary vascular disease, bronchiolitis, toxic inhalations, cystic fibrosis, pneumothorax, ARDS, restrictive lung diseases, upper airway obstruction, and anxiety attack. It could be gastroesophageal reflux disease or sepsis. How do we work up patients with COPD in terms of our investigations, guys? So probably the most important thing to do are your pulmonary function tests. This is the gold standard for diagnosis and will definitely demonstrate an obstructive pattern. So you got a decrease in your FEV1 to FVC ratio, which is forced expiratory volume in 1 second over the forced vital capacity. Usually it's less than 70% predicted, and this is the best indicator of obstruction. Right. FEV1 in general is a good marker for severity of most pulmonary diseases. Okay, you also have increased lung volumes in the way of increased forced residual capacity, increase in your residual volume and your residual volume to total lung capacity ratio, which may occur because of airway obstruction, resulting in air trapping and hyperinflation. A decreasing DLCO, which is diffusing capacity of carbon monoxide, is common in emphysema, right? Full blood count may reveal polycythemia secondary to the chronic hypoxemia. A chest X-ray may reveal flattened hemidiaphragms, hyperinflation, may see emphysematous bullae, increased lucency in the lungs, a small kind of tubular heart. However, what's important, guys, is that the radiographic appearance does not correlate with the degree of lung dysfunction. The radiographic appearance does not correlate with the degree of lung dysfunction, right? CT scan may reveal centrilobular emphysema and bullae and may actually be used to rule out other lung diseases. Laboratory evaluation in COPD exacerbation includes a full blood count with differential serum chemistries, your arterial blood gas, very important, and ECG. So the arterial blood gas reveals typically hypoxemia, low PO2. Why? Because ventilation perfusion mismatch, and elevated PCO2 with acute respiratory acidosis. If this is a grumbling, long-standing process, your bicarbonate will also be high as a chronic compensation for the CO2 retention. Chemistries may show a compensatory metabolic alkalosis. So you have elevated bicarb, that's what we said. Alpha-1 antitrypsin testing is useful only in the context of predominantly lower lobe disease in those without a history of cigarette smoking, okay? So here is the gold classification, right? Let's get my pen in there. So it's the COPD severity assessment. So COPD severity categories are based on respiratory symptoms based on the MMRC dyspnea scale or on the COPD assessment test, CAT, and as well as looking at the annual frequency of COPD exacerbations, right? The MMRC provides a single number for degree of breathlessness. So 0 is breathlessness only with strenuous activity. 1 is breathlessness when hurrying on level ground or walking up a slight hill. 2 is breathlessness when walking slower than peers and stops walking at their own pace. That 3 is walking about 100 yards or so or after a few minutes on level ground. 4 means the patient is too breathless to leave the house or when dressing. And the CAT, the COPD assessment tool, is an 8-item COPD health status measure with scale responses for questions about cough, phlegm, chest tightness, dyspnea on one flight of stairs, limitation in home activity, confidence in leaving the home, sleep, and energy. The range of scores from 0 to 40, okay? So basically, when we look at the symptoms as per the MMRC scale or the CAT score, and we look at the exacerbation history, right? And we look at the symptoms. We can subcategorize our COPD patients into one of four groups. Group A, B, C, or D. So A is basically where there's low symptoms and low risk of exacerbation. B is where there's high symptoms but low risk of exacerbation. C where there's low symptoms but high risk. And D where there's high symptoms and high risk. And this portends different treatment modalities, which we will talk about later. Okay. This is the gold criteria for severity of airflow obstruction in COPD. And what we can appreciate is there's four stages: gold stage 1, 2, 3, 4, which correlates with mild, moderate, severe, and very severe based off the FEV1 FVC ratio and the FEV1 in terms of what's predicted, right? So, say gold stage 1 means mild disease with the FEV1 FVC ratio below 0.7. All of them fit this criteria because it's obstructive airway disease, but they differ in terms of the FEV1. So, in stage 1, the FEV1 is greater than 80% predicted. In stage 2, which is moderate, the FEV1 is between 50 and 80%. Stage 3, FEV1 between 30 and 50%. Stage 4, FEV1 below 30%. So, as we see, as we progress from stage 1 to 4, the FEV1 is significantly decreased in comparison with what is predicted. Alrighty, so here we see different CT patterns of emphysema. So let's just get my pointer in there. So in A, we see sensory lobular emphysema with severe upper lobe involvement. You can see these massive bullae in there. In a 68-year-old man with a 70-pack year smoking history, and his FEV1 is 81% predicted. So his goal spirometry, grade 1. Here in image B, we see panlobular emphysema, so bullae all throughout the lung fields, with diffuse loss of lung parenchymal detail, predominantly in the lower lobes, in a 64-year-old man whereas severe alpha-1 antitrypsin deficiency is predominantly lower lobe involvement. Remember, this in a non-smoker is a harbinger, or indicator rather, of alpha-1 antitrypsin deficiency. In image C, we see paraseptal emphysema with marked airway inflammation in a 52-year-old woman with a 37-pack history and FEV1 40% predicted. So that's gold stage C. Alrighty, so here we're looking at the hypothetical tracking curves of forced expiratory volume in 1 second for individuals throughout their lifespan. So the normal pattern of growth and decline with age is shown in curve A. Here on the x-axis is age, and on the y-axis is FEV1 percentage of the normal level at age 20. So the normal is going to be A, right? But a significantly reduced FEV1, less than 65% of predicted at age 20, can develop from a normal rate of decline after a reduced pulmonary growth function growth phase, which is curve C, right? We see here reduced growth. Early initiation of pulmonary functional decline after normal growth, which is curve B, or accelerated decline after normal growth, which is a rapid decline in terms of group D. Guys, let's talk about treatment and management now. Avoiding cigarette smoking is the only way to slow disease progression, and the only interventions really which have a significant impact on reducing mortality are smoking cessation and home oxygen. Okay, patients presenting during acute exacerbations require immediate respiratory intervention. You want to administer supplemental oxygen during acute exacerbations with a target saturation of between 90 to 92% by pulse oximetry, which correlates with a partial pressure of oxygen of between 60 and 65 bars mercury, which ensures optimal hemoglobin saturation and decreases the possibility of hypercapnia by suppression of respiratory drive. So normally remember that our respiratory center depends on the partial pressure of CO2 to drive respiration, but in COPD your CO2 is predominantly increased most of the time. So the respiratory center now depends on your partial pressure of oxygen as opposed to the PCO2 to regulate and drive respiration. If you diminish that respiratory drive by giving too high a percentage of oxygen, you may actually impede respiratory drive, which is why we aim for oxygen saturation between 90 to 92% and no higher. Inhaled bronchodilators in the way of beta agonists plus anticholinergics remain the mainstay of pharmacological therapy and should be used immediately in acute exacerbations, nebulized. Begin with continuous nebulizer treatments and then decrease to every 2 to 4 hours as tolerated. What's as important as that is the use of systemic corticosteroids. We use intravenous hydrocortisone or oral prednisone have been shown to improve symptoms, airflow, and gas exchange in acute exacerbations. They have also been shown to reduce the rate of treatment failure and shorten hospital stays. So you know how we went through the different stages, different groups in COPD classification as per the GOLD guideline. So here this portends treatment options, right? So we said based off the symptoms, that's the MMRC scale or the CAT score, and looking at the risk of exacerbation, right? So on the left, we have 0 to 1 moderate exacerbations not leading to hospital admission. On the lower line, on the upper line, more than 2 moderate exacerbations or more than 1 leading to hospitalization. So if you are group A, we simply use a bronchodilator. It could be a short-acting beta agonist or antimuscarinic. In group B, we opt for a long-acting bronchodilator in the way of a LABA, which is a long-acting beta agonist, or a LAMA, long-acting antimuscarinic. In group C, we use a LAMA, which is long-acting antimuscarinic. In group D, we use a LAMA, or a LAMA and a LABA, or an inhaled corticosteroid and a long-acting beta agonist. Consider especially if the patient is highly symptomatic with a COPD assessment tool score of above 20, and also consider if your eosinophils are above 300, okay? And then in terms of your follow-up pharmacological therapy, if the response to initial treatment is appropriate, then we're simply going to maintain it, right? But if not, you want to consider the predominant treatable trait to target, which is dyspnea or exacerbations, and use the exacerbation pathway if both exacerbations and dyspnea need to be targeted. We place the patient in a box corresponding to the current treatment and follow indications. Assess response, adjust, and review. And these recommendations do not depend on the ABCD assessment of the diagnosis, right? So if you're dealing with exacerbations, right, then you want to offer either a long-acting beta agonist or a long-acting antimuscarinic, right? And from there, you want to either add on inhaled corticosteroid or you can supplement LABA with LAMA, right? And then if that doesn't work, you want to consider triple therapy with a long-acting beta agonist, long-acting antimuscarinic, and inhaled corticosteroid. And to that, we can also add roflumilast, which is a phosphatidylserase 4 inhibitor, especially if your FEV1 is below 50% and predominantly chronic bronchitis. And in former smokers, azithromycin because of its immunomodulatory effect. If the patient just presents with dyspnea, you consider LABA or a LAMA, or you can add both together with inhaled corticosteroid. And consider switching inhaler device or molecules, investigate and treat other causes of dyspnea as well, like pneumonia, like pulmonary edema, like pulmonary embolus. All right. Now, antibiotics like azithromycin should be administered particularly in acute exacerbations or if there is evidence of pneumonia. Regimens in acute exacerbations which we think have an infective precipitant should include antibiotics directed against common pathogens like strep pneumonia, Moraxella catarrhalis, Haemophilus influenza, especially among smokers. Ventilatory assistance may be deemed necessary in the way of non-invasive mechanical ventilation via CPAP or BiPAP, which is continuous positive airway pressure or bi-level positive airway pressure, which are needed to avoid the need for intubation. Indications for acute airway intubation include number 1, inability to protect the airway, number 2, agitation, number 3, respiratory arrest, number 4, failure of our non-invasive measures. Okay, guys, let's talk prognosis and complications. COPD causes significant morbidity in a large number of patients. However, the majority of deaths occur in patients with severe cases. In most clinical situations, COPD is manageable but not a curable disease. Lost lung function is rarely recoverable. Inpatient hospitalization for acute exacerbations has a 5 to 10% mortality rate. Intubation and need for mechanical ventilation increases mortality to above 20%. Because of concomitant risk factors of cigarette smoking, patients with COPD have a very, very high chance of lung cancer. Guys, coming back to our clinical case, we had an elderly gentleman here, right, who is known with COPD. He has been stable without exacerbation for the last 6 months. He feels in poor health and he's dyspneic upon usual activity. He's only on a short-acting beta agonist. He has 50-pack history of smoking, quit 5 years prior. He also has peripheral vascular disease, hypertension, BPH, right? He is managed on aspirin, lisinopril, hydrochlorothiazide, tamsulosin. He has resting oxygen saturation, 93% room air. He's hyperinflation. His PFTs demonstrate FEV1 of 55%, FVC of 80% predicted, and a ratio of 50%. So in terms of spirometry, he is gold class C. What's the next step in managing him? The answer is start tiotropium, which is a long-acting antimuscarinic, right? So the patient has a known diagnosis of COPD with worsening symptoms and PFTs consistent with a moderate degree of disease. By gold criteria, he would be stage 2 disease already. The best initial medication for this patient would be simply to add a long-acting bronchodilator in the form of the antimuscarinic agent tiotropium. Okay, my friends, let's just talk about the Bible for a bit. The book of John chapter 9 verse 4, Jesus says, as long as it is day, we must do the work of him who sent me. Night is coming when no one can work. My friends, now is the time to put our faith and trust in the Lord Jesus, right? The Bible tells us that indeed there is a time coming and has now come when the true worshippers shall seek the Father in spirit and in truth. The Bible says, seek the Lord while he may be found. Call on him while he is near. That implies there is a time coming when the Lord will not be found. So do not delay in seeking the Lord and in serving him with your whole heart. Okay, these are my references, everybody. Thanks so much for joining me. If you enjoyed this content, I strongly encourage you to like, share, and subscribe. Thank you so much. You can catch me on Facebook. Just search for Internal Medicine Algorithms and Mnemonics to get many more resources, helpful resources in internal medicine. You can also catch me on Instagram and on TikTok as well. God bless you. We're going to be talking about adult polycystic kidney disease, or autosomal dominant and autosomal recessive flavors of PKD, and tetanus. Those are topics to look forward to. God bless you. Have yourself a wonderful day.